Good afternoon, everyone. My name is Awili Chofle. I'm an infectious disease and medical microbiology consultant at the University Hospitals Monklands, Cambridge and Wishaw in Scotland. And I've been asked by FRCPath trainees, UK trainees, to put together a bit of a summary of how would have approached the exam. And I've decided to put this summary together to help for the trainees who are preparing for the FRCPath exam part 2. As you're aware, this is an exit exam for UK trainees, but is also available for international trainees. And probably this overview will be important for the trainees who are planning to sit for FRCPath microbiology exam part 2. Therefore, this is my approach, and it's not by any means comprehensive. You can adapt according to your plan, but this is just my approach to FRCPath when I was preparing for this exam. Without further ado, I'll start showing you what was my plan. Therefore, there are different ways of doing things. My approach was look at the exam format first, and look at the curriculum, and then resources. Otherwise, some people may do differently. They look at the resources first, curriculum and exam format. Both ways are acceptable. The aim is to pass the exam. And if you have not watched this video, I will suggest you go to FRCPath website and watch this video. Is a very informative video, as the title suggests. Therefore, my approach was to look at the curriculum first, and I looked at the curriculum. As you know, the curriculum changed while I was in training. Therefore, we had to adapt to a new curriculum. Therefore, we moved to a new curriculum, I think, in 2022, if I'm not wrong. And as well as looking at the curriculum, you look at the exam format. The exam format has changed several times in the last 5 years. And then this is the latest version of the current exam format. Therefore, the top part is FRCPath part 1, and the second part is FRCPath part 2. For the sake of this presentation, we're going to concentrate on FRCPath part 2. And as you can see, the first sentence says it's recommended FRCPath part 2 is attempted for the first time towards the end of the first year of higher infection training. Therefore, the infection training depends. If you're doing microbiology only, it's 4 years. If you're doing microbiology with infectious diseases, is 5 years. And you can either do at ST5 or ST6. Some people usually do the exam 6 months before they complete their training, but it's a bit of risk. If you don't pass, means you won't complete your training. I did mine in ST5, therefore that is very, very early after during the first year of higher training. Therefore, this is just an overview of from a curriculum, and you can see it's labeled in alphabetical order, J to R. And these are the topics. And then the problem with this topic is just one liner. You need to put the flesh on it, which I will explain later. The important clinical syndromes I've tried to list myself. These are the important clinical syndromes. And on the red, these are probably more important than others. Therefore, I spend more time doing the red bit more than the black colored list. And you can see these are favorable FRCPath exams. From the top, pediatric infections and pregnancy-associated infection is almost a given. You'll have that question in your exam. And the primary and secondary immunodeficiencies tuberculosis and other mycobacterial infections. This is a very common exam because it cut across microbiology bench, microbiology safety, microbiology MDR. In my exam, we had an MDR, but the story, you need to get into the story to understand that that was an MDR. The story, the way they put together, someone from Southeast Asia, previously treated for TB, and now coming again with tuberculosis. Therefore, the question might direct you to know whether this is an MDR or not. And then they'll ask you what are the presumptive regimens you can use for that type of patient. And the questions will go down and try to help you to narrow down to a very specific regimen. Cardiovascular infections, skin and soft infections, very common. Bone and joint infection, even common. Gastrointestinal and hepatic, pancreatic, biliary. Therefore, usually the way they shape the question on gastrointestinal and hepatic, pancreatic, biliary infections is, are you aware of some of the clinical syndromes whereby antibiotic is not a primary management? Things like necrotizing pancreatitis. Are you aware of that? That will be a question. And then they'll talk about this patient has drains and the patient has no fevers, the patient is doing very well, they've cultured drain fluid, and they're asking you, would you treat this? It cut across the understanding of infection, understanding of colonization, understanding when to treat, and the question comes as a package to test you at different scenarios of these gastrointestinal and hepatic, pancreatic, biliary infections. Neurological and ocular infections are very common, and they usually here they come as pen allergy, ocular infection, someone alcoholic, not adhering to the treatment. What are you going to do? But they usually guide you to a very specific answer. Next, imported infections. These are very important. As you can see, is well stipulated in the curriculum. Most of the questions are usually in part 1, but get ready for part 2. They might ask you about imported infections. IPC, therefore the infection control and prevention, the way it's asked is asked at different levels. Therefore, almost each question, they will have a component of an IPC. Therefore, IPCs, parts and pieces of each question, but we had a complex case scenario on IPC, and this was a theater transmission of infection. It was a big question, 4 pages of data, and if you look at 3 hours exam, you have 5 complex case scenario and 10 short answer questions. Therefore, if you divide, you put 90 minutes on each side. 4 pages is a lot. You don't need to spend more than 20 minutes in each question of a complex case scenario, including reading and writing. Therefore, you have 90 minutes for everything. And the IPC was, I think the whole question was just an IPC, looking at the theater transmission of infections at different scenarios. They give you a scenario of theater 1, theater 2, theater 3. The question was very complex. Therefore, you must have a way to approach these complex questions at a good speed, understanding the question, as well as making sure you're getting it right in the end. Properties of antimicrobial agents, as you know, this usually comes in both short answer questions as well as in SPE, which we'll come to explain later. They will ask you class of antimicrobial agents, their mechanism of actions, spectrum of activity, route of administration, dosing, penetration, side effects, and resistance. You need to go through each class of antibiotics, and at least you need to know everything about that antibiotic. The pharmacokinetics, pharmacodynamics are very important. They will ask you if I don't remember well, but we had a question on tazocine, a pregnant, a postpartum patient who had puerperal sepsis went home on tazocine. I think instead of being given tazocine 3 times a day, was in like 8-hourly, was given all 3 times a day within 10 hours, and they want you to explain what went wrong, and they want you to answer the rest of the questions. Therefore, PKPD comes in, and you need to understand that why tazocine is supposed to be given 8-hourly or sometimes 6-hourly. Therefore, what I decided, I summarized this. I got from this one from my friend, and I had to adopt it and put the way I understand. Therefore, this is a summary of just antifungal, but I did the same for antibiotics. Therefore, you have a class, you have a spectrum of action, you have mechanism of action, mechanism of resistance, and so on and so forth. This is just an example. You can do the way you want to do, and you can do the way you think is easier for you to remember. Antimicrobial stewardship. Therefore, each question has an antimicrobial stewardship almost. And the antimicrobial stewardship is, did you choose the right antibiotic for this patient? Did you choose a right empirical or a right pathogen-specific antimicrobial for the treatment of this patient? Did you understand the global problem of increasing in antimicrobial resistance? Do you know the code that WHO have put, the red, the green, the other colors as well? Therefore, you need to know appropriate use of outpatient parenteral antimicrobial therapy and the follow-up of the patients. Again, same thing, use of antimicrobials, hypersensitivity, optimal duration of therapy. These are the questions you'll be asked. And almost in each question, they'll tell you this patient is allergic to penicillin, and you need to choose an antimicrobial that is not penicillin. I think, if I remember well, we had a patient with actinol, and we were told that the patient is pen allergic. You need to manage this patient by treating the actinomycosis, as well as avoiding penicillin because of the patient was sensitive to penicillin. Vaccination is well covered in part 1, but be aware that this might come as an infection control scenario, like a Hep A scenario, or this might come as UK schedules of immunization or immunization to healthcare workers, splenectomy patient, exposure prophylaxis in rabies, Hep A, Hep B, as well as boosters for pre-existing immunity. Therefore, it's very important to read the Green Book. Therefore, how did I prepare? This is my preparation is not necessarily ideal, but this is what I did. I was planning to do my my part 2 very early in my training. This is like 3-4 years back. And then what I did is I attended the courses that I thought they were key for my preparation, including the practical clinical microbiology for annual course. And this is a course run, I think, once a year in Cardiff. It's a 2-day course, very comprehensive, and if you can, is face-to-face. Therefore, you need to travel. It's easy for UK trainees, but difficult for international trainees. I also attended the Leicester mock, and this was I think 3 or 4 weeks before my exam. The Leicester mock is very hard. I should warn you. I'm not sure if I got even 50% of the Leicester mock. The questions were long. I was timed out on each question. The other course I did up which I've not listed here. I did foundation course for infection control, as well as we had a locally organized prep questions and vivas, BISAC questions on antimicrobial susceptibility. Public Health in Scotland. I attended a day in Public Health Scotland just to see how public health people are doing their things. And then I attended meeting his BIA and fees. These are annual meetings. In UK, we have twice, I think, BIA fees once, and multiple his meetings. Some are online. Good preparation for the exam. How did I prepare? It took me almost 12 months. Therefore, I would suggest probably it depends with your background knowledge. You can prepare for this exam between 6 months and 12 months. We have a Scottish infection teaching every Wednesday. Therefore, I had a chance to attend these teachings every Wednesday, and the teaching is organized according to the curriculum. The SMIs are very key for this exam. There are so many guidelines, I can't mention all of them. You can register yourself with the UKHSA alerts. Green Book is a key. UCAST website, you can learn about resistance mechanisms and all the new breakpoints and the new antibiotics. Pro-Implant Foundation Pocket Guide is free. You can read CDC Monthly Parasitology Spot Quiz, Adelaide University Mycology Online, and the reference books like Mandel and Conant, and MCQs as well. European and the IDSA guidelines, there are some differences between the two guidelines, but the exam allows that. Therefore, whether you use your European or your IDSA, you're not necessarily wrong as long as you're given the right treatment. Like there are some differences in ocular fungal infection, but they're all acceptable. Fungal endophthalmitis is one of the very important questions in our exams, and you need to prepare for that. Therefore, there are so many guidelines. ESCMID have their own guidelines. You can read them. The most important is the knowledge and the safety. Therefore, when you're answering your question, someone who is marking you and can understand you and think that you are a very safe doctor, there's a very high chance they will give you a full mark. Pathology portal, this is new, came I think 2 to 3 years ago, for mostly for UK trainees, but I'm not sure if you can get a login with an email that is not an NHS email, but probably I'm wrong, I don't know. Group discussions are very important. Therefore, there's a microregistrar.com group whereby you have a lot of resources. WhatsApp group. The WhatsApp group it really depends how active you are. And in the WhatsApp group that I was writing questions for the group, and that makes me easy. Therefore, I was writing the question and people are responding to the questions, and that makes like an active participation. Also, we have MS Teams with 2 to 3 people who are discussing. We're discussing almost every day. Their Twitter antibiogram by Wright. You can see the handle there, and you can follow him. His account was hacked recently, therefore the old questions have disappeared. ID Fellow Camp, this is an infectious diseases fellow camp. We had a group that we attended for many years. And the online mock exam, this is my plan to prepare the online mock exam for you guys. Therefore, watch the space and keep on coming to my YouTube channel. I'll start posting the online mock exams on my channel. There are so many guidelines regarding the health technical memoranda. This is one of them, ventilation, technical memorandum for safe water, environmental, management of decontamination of surgical instrument, decontamination of linen, health and social care, decontamination of flexible endoscopes. You will see I'll be posting questions from all this memorandum. The IPC experience I've explained already, foundation IPC courses that I did for, I think, 5 or 6 days at that point. The HTM guidance are well discussed in this foundation course. Theatre commissioning is the key, no CJD guidance for endoscopy and surgical equipment. You can visit sterile services and endoscopy just to understand. In Scotland, we have PAGS. PAGS is when you're not sure whether this is an outbreak or not, and you reconvene with 2 or 3 colleagues to discuss. And after discussion, when all the colleagues are saying, yes, this is likely an outbreak, therefore that's it's just a stage before the declaring an outbreak and then having an outbreak management. Know how to deal with laboratory cut 3 spill. This is like a very standard question. And use read all the resources from UKHSA, all the PHE guidance about Candida auris, CPE toolkits, and HCID. The antimicrobial fundamental concepts, the PKPD, as I've explained in the question of tazocine in my exam there, but this is very important. The newer antibiotics, they're not new anymore if you look at the names now, but they keep on asking on this, the new antibiotics. Therefore, try to look at what's coming, what's in the pipeline, and make sure you are aware of these antibiotics and the coming antibiotics. Carbapenem-resistant Enterobacterales. Therefore, this is a very good paper by Livermore. Livermore has summarized almost in 1 page. It is the mechanism of resistance, and they can see. I usually follow him. He's one of the microbiology professors worked previously at PHE or UKHSA, and he has wrote a lot of papers and literature on antimicrobial resistance. Therefore, this is just part of one of his papers. Just in 1 page, you get a glance of the KBC, the OXA48, NBL, and Pseudomonas, and the Enterobacterales. Yeah. And this is the same paper going into details to explain how to spot an OXA48, how to spot an OPRD loss, and all other stuff. ESCMID have their own guidelines. They're very good if you look at them. And then public health, you need to know all the typing about the TB. We do typing a lot of organisms, but probably these are the key: typing of TB, MSSA, and MRSA. The methods that are used for typing: C. diff, E. coli, Klebsiella, CPE gene, plasmid, and all other stuff. The FRCPath have a favorable gram-positive bacilli organisms, and then in the lab we usually just ignore them unless they are coming from a sterile site, but it's very important to read them through, and these are just some of them. I remember we had nocardia in our exam, we had listeria in our exam, we had bacillus in our exam, we had nocardia. Therefore, it's just to tell you, don't ignore them, read them thoroughly, and read them through all their characteristics. Therefore, gram-positive bacilli and the clinical differential diagnosis I've tried to put together. Therefore, may come as a question on prosthetic material, which is, these are sterile sample, you treat them, intra-abdominal infection, you'll make your decision. Skin and soft tissue infection, some of them may cause gas gangrene and necrotizing fasciitis. And these are all the syndrome: meningitis, encephalitis, cerebritis. My question was, we had a listeria, thromboencephalitis in our exam, endocarditis, mycobacterial infections, and some may be just a contaminant. Therefore, you need to be aware of gram-positive bacilli. The clinical diagnosis, this is just to insist on looking at your gram-positive bacilli, prosthetic joint infection, Corynebacterium, Proprioni, especially on the shoulder replacement, prosthetic cardiac material, coronae, proprione, venous catheters, coronae, proprione, meningitis, as I've explained before. Therefore, let's come to the format of the exam. I think I'm trying to come to the end of my presentation. Therefore, the format of the exam is there's a paper 1 and paper 2. The way the exam is conducted, you'll be divided into 2 big groups, and you'll be probably hundreds of people. They will divide you into 2. Therefore, in the morning, one group will start with paper 1, the other group will start with paper 2. The group that started with paper 1 will swap and do the paper 2 in the afternoon. The group that done paper 2 in the morning will do the paper 1 in the afternoon. My exam, I started with OSPE, and it was the morning. Therefore, what I did my OSPE first. The way the exam is done is, these are stations, but you're given a folder. The folder has all your questions, and usually they call them 15 stations, but you have more stations. There are 2 rest stations and 2 viva. Therefore, when you reach your viva, there are 2 questions on viva. You go out of the room and queue to do your viva. You do your viva 1 and your viva 2, and then you come back. You may start with a rest session again, or you may start with a question. It really depends with how the numbers and how it has been planned. The OSPE time is controlled. Therefore, each question is 9 minutes. You sit down, attempt the question. The invigilator will tell you, stop writing, move to the next question, and you take that paper, you put in the next envelope, and you take the next question. You don't fiddle around the papers to choose which one, because that's the arrangement. You need to follow the arrangement so that you know your time for viva and you go out. Total marks, paper 1 has 200 marks. There are 5 complex clinical scenarios, and there are 10, that my exam had 10 short answer questions. You are given both envelopes for complex case scenarios and for short answer questions. It is entirely up to you to choose where you want to start. Therefore, with time and the number of marks, I went with the complex case scenario. I did the complex case scenario. Sorry, I said 3 before. No. The complex case scenarios were 5. I did them first and finished them, and then I moved to short answer questions. And in the short answer questions, you don't need to write a lot. You answer the questions. The OSP, as I've explained, there are 15 stations, 2 are viva, and then 2, I think, are rest stations. The topics are wide range of topics: laboratory practice, clinical infection scenario, infection prevention, pictures of gram stain. They give you a hint of a bit of a story, and then a picture of gram stain. They want you to identify the organism. Therefore, it's like if you're very good on bench microbiology, the OSPE is easy for you. OSP format and tips. Therefore, as I've said, you receive your envelope. You have 9 minutes in each station, and you have 2 rest stations, and you have 2 vivas as well. Therefore, the OSP questions, there's 1 question that is given, which is data interpretation and research method. They usually choose one of the articles that, like in my exam, I had Merino trial, and they either ask you a flow of the clinical trial, interpretation of the data. They can ask any question, and that, I'm not sure of the marks, but it carries a bit of a higher marks compared to other questions. The other OSP example are like fungal infections, parasitology, sports, infection prevention, laboratory management, virology, and bacteriology. For complex case scenario, therefore, this is the way they put together a question. Therefore, there'll be a clinical scenario, a presentation, a bit of investigation, and the questions will be coming in slowly, then treatment, then infection control, then follow-up. You see, and these are the key topics we've discussed already. Short answer questions include infection control, things that are going to reference laboratory, water safety, the Legionella in water supply, the typing of specific organisms like Clostridium, Salmonella, in infection in children. You need to advise the GP, Candida auris. All these are key infections that you, as a microbiologist, you need to be aware. And then short answer questions I've explained previously. These are the questions I can remember from exam. Listeria in neonates. They can give you a story about the twins and all other stuff. Solid organ transplant, HIV positive. These are some of the scenario I can remember. MRSA susceptibility results and the interpretation. And then describe for antibiotic results and describe the importance of PBL and all this typing. Candida in urological infection, kidney and urinary tract, and a family recent. This was one of the questions. I'll leave you to read. Family recently returned from Saudi Arabia, visited a desert, had respiratory symptoms. As we can see, they were trying to make sure you understand MERS and the geographical interpretation of infection and imported infection. And after exam, you've done what you have done. You don't need to worry. It's out of your hands. You just need to relax and wait for your results. But there are some good news in our exam in autumn. This were the results. I think the pass rate was good. Last but not least, again, this is the way I approach my exam. You look at the exam format, you look at the curriculum and what are the resources and how would you prepare yourself. And I'll be happy for you to put some questions on my channel and I'll try to respond as much as I can. And watch the space. I'll be putting questions and please, I'm inviting you to follow me and answer all the questions and I'll try to give the model answers. And thank you. And those are my contacts if you want to email me or call me. Thank you.